This is 1 out of 40 previous year topics for NEET PG 2025. The topic is Cushing syndrome. Most of the questions from this topic have come from the evaluation and management. But before we delve into the evaluation, let's look at this brief physiology. The corticotropin releasing hormone is produced from the hypothalamus and it acts on the pituitary gland to produce ACTH. ACTH acts on the adrenal gland to produce cortisol. And the cortisol can negatively inhibit the production of ACTH from the pituitary gland. This is negative feedback loop. This can be tested by using investigations. You can test this hypothalamo-pituitary adrenal axis from the top by giving CRH and see whether the cortisol is produced or not. Or from the bottom by giving dexamethasone, thereby suppression of ACTH and the cortisol is reduced or not. When you look at the lab investigations, you can see these. The glucocorticoids will have a mineralocorticoid action as well. That is why there is sodium and water retention, potassium excretion and H+ excretion. Because of this, the patient will have hypokalemia and metabolic alkalosis. Now the diagnosis. Diagnosis has two steps. Number 1, screening or confirmation of the diagnosis of Cushing syndrome. Number 2, finding the cause. The confirmation of diagnosis of Cushing syndrome requires any of these investigations. 24-hour urinary free cortisol excretion, midnight salivary cortisol. If any of them are increased by more than 2 times the normal levels, then it indicates Cushing syndrome. Or you can also do overnight 1 mg DEXA suppression test. If you are still in doubt, for confirmation, you can do low dose dexamethasone suppression test. Now find the cause. For that, look at plasma ACTH level. If the ACTH is normal or high, then it is called as ACTH dependent Cushing's. So the Cushing's is because of ACTH production somewhere in the body. Now look at MRI pituitary to look for pituitary adenoma. Test from top, do corticotropin releasing hormone test. CRH stimulation test. By giving CRH, see whether the cortisol is increased or not. Number 3, test from bottom, high dose dexamethasone test. Again, check whether the cortisol is suppressed or not. If the cortisol is suppressed, then the HPA axis is intact, then it is Cushing's disease. That is Cushing syndrome originating because of pituitary adenoma. If it is not suppressed, then the ACTH is produced from somewhere. It is ectopic ACTH. If the results are not clear, then do inferior petrosal sinus sampling for ACTH level. If the ACTH is increased, then again it is Cushing's disease. On the other hand, if the ACTH is low, then it is ACTH independent Cushing's. The probable cause could be an adrenal tumor. For that, do CT abdomen and look for bilateral adrenal hyperplasia or adrenal adenoma or adrenal carcinoma. Any of them can be found. Now the treatment. If it's a Cushing's disease, the problem is at the pituitary level. That is why the treatment of choice is transsphenoidal pituitary resection. But prior to the surgery, you want to control the hypercortisolism. That is why there is medical management. You can use metarapone, ketoconazole, osilodrostat, mitotane or etomidate. If the patient is having exogenous Cushing's, that is, the patient has developed these clinical features because of exogenous steroid usage. Drugs. The treatment would be gradual tapering doses of steroids. Do not immediately stop the patient off steroids because it could result in adrenal insufficiency. If you find value here, please like this and share this with your buddies.